Good afternoon, everybody, and welcome to American Safety Programs and Training. Chapter Review, Chapter 22, Psychiatric Emergencies. So, in Chapter 22, we're going to discuss what is a psychiatric emergency. We're going to talk about some of the myths about what people who are going through a psychiatric event or situation, what's true and what's not true. We're going to discuss the behavioral crises. We're going to talk about the pathophysiology of a psychiatric emergency. We're going to talk about the safety guidelines that as an EMT, as a caregiver, what you need to be aware of to keep yourself safe, your partner safe, and the patient safe as well. Then we're going to briefly review patient assessment, how to go about doing it, what to keep an eye out on. We're going to briefly discuss psychosis. What is psychosis? And what is an acute psychosis? What is excited delirium? We're going to talk about, for those few times that's required, if you have to restrain a patient because they're a danger to themselves or others. What are the legal issues that are involved? What do you do with the potentially violent patient? What do you do when you're dealing with a patient who has a suicidal ideation, who has attempted suicide, or somebody who wants to attempt suicide? What do you do, or how do you deal with the patient with PTSD, a veteran who has PTSD? We're going to talk about the legal issues of consent. You have implied consent and you have express consent. And then lastly, we're going to just finish it up with the elderly. You're going to deal with a lot of elderly individuals as patients. It's very common to be called to assisted living facilities, to nursing homes, to group homes, who have the elderly, who have geriatric patients, and it's very common for them to have any type of dementia, Alzheimer's, or depression. How do we deal with that? What should we be concerned with? Okay. Out of everything that you're going to learn today, some of the most important things you can walk away with is just because someone has experienced a psychiatric emergency does not mean that they're dangerous. Does not mean that anybody and everybody who has a psychiatric emergency is a danger. Some people have them because of multiple reasons. There's a wide variety of reasons why people have a psychiatric emergency. And psychiatric emergencies is an umbrella. It covers a lot of type of situations that you're going to encounter. It's an umbrella that covers a lot of different situations. Okay? So, first of all, behavior. Just like signs and symptoms. A sign is what you see, a symptom is what the patient tells you. Behavior is what you actually see the patient doing, how they're acting, how they're talking, how they're breathing. Are they sitting down? Are they talking actively the way we will be talking if we were in class? Do they seem overexcited? Are they jittery, jumpy? Are they bouncing off the walls? Or are they acting very lethargic, almost unconscious, in and out of consciousness? Or do they seem depressed? They don't want to talk to you. Do they seem mad? Do they seem sad? Okay, we can all come up with a general idea fairly quickly on the person's behavior. But people call 911 for an ambulance and or maybe police because somebody's behavior, because somebody's acting different, somebody's acting weird, something doesn't seem right. They don't know what's going on, so they call 911. Okay? Well, a behavioral crisis is when somebody is exhibiting an agitated or a violent or an uncooperative behavior, which people are interpreting that behavior could be a danger to themselves or to other people. They may be right, they may be wrong, but that's how they're interpreting that person's behavior. Okay? Now, there's a couple things that people go through. We all know what depression is, and we all know what depression is. Okay? It's just a feeling of sadness and despair. Well, you have people out there who have chronic depression, and they feel like that all the time. Most of the time that can be dealt or treated with medications to help bring their mood up a little bit. You see commercials for that type of medication out there. Other times, it's the person's environment that's making them feel very depressed all the time. It could be their living conditions. Okay? So we know what behavior and we know what behavioral crisis is. We know what depression is. But what about a psychiatric disorder? Okay, a psychiatric disorder is just basically an illness with psychological or behavioral symptoms that can result in the impaired functioning of the person. Okay? It means that somebody is going through a situation in their lives that they're having a really hard time dealing with. And in having a difficult time dealing with that, they're not functioning on a daily basis the way the average person should. It could be that somebody has PTSD. They just got back from the Middle East and they were involved, they saw one of their best friends pass away or get killed. And they're having a really, really hard time dealing with that. They want to stay inside the house all day. They don't want to go out. They don't want to talk with anybody. They just want to be left alone. Okay? Or they get very edgy around crowds. If they're in a crowd of people and they hear a big bang, like a kid popping a balloon, like we see in the movies. Or they hate the 4th of July because of all the explosions from the fireworks. If they feel like they're back in a war zone. Okay? It could be that somebody has high anxiety all the time. It could be, excuse me, it could be that somebody has panic disorders. And a panic disorder is just something, basically, somebody's always, excuse me. It could be that somebody has a high level of anxiety all the time. You have chronic anxiety. And because of that, they're always panicking over the simplest, littlest things. Things that you and I would think nothing of. Or it could be that somebody has a obsessive compulsive behavior. Obsessive compulsive behavior is they have to wash their hands every 5 minutes because they think they're dirty. Everything has to be perfect on the desk. Everything has to be perfect wherever it is. Nothing can be out of place. Okay? Well, very briefly, let's talk about pathophysiology. Okay? Doctors are going to describe, or basically doctors are going to use two categories when they're describing or when they're diagnosing somebody with a psych issue. It's either going to be organic or functional. Now these are things, it's a good idea just to have a general idea, to be familiar with them, but we're never going to use these in the field. We're never going to diagnose patients in the field. That's for the MDs to do. But when the MDs do diagnose them, they usually put them into one or two categories, either organic or functional. And organic, otherwise known as organic brain syndrome, is just basically a temporary or permanent dysfunction of the brain caused by a disturbance in the physical or physiologic functioning of the brain or brain tissue. Okay? So there's been a disturbance to the physical or the psychologic functioning of the brain because there's something wrong with the brain tissue. It could be the way that the brain developed when they were a baby. It could be because they had a traumatic brain injury, a TBI. Say they were involved in an accident, car accident, and their head hit the windshield really, really hard. Say they were diving in a pool, and they dove in the shallow end, and they went down and their head struck the bottom of the pool. Say they were rock climbing, and they fell and their head hit a rock really hard. That'd be a traumatic brain injury. Okay, it could be somebody who has seizure disorders, somebody who has excessive drug or alcohol abuse, where they overdosed. It could be a situation where there's a patient is diagnosed with meningitis. Okay, meningitis, as you know, is an infection of the meninges, and the meninges is the protective coating that covers the brain and the spinal column. When that becomes infected, it becomes a life threat. It's very, very dangerous. So that could give somebody altered mental status. Okay, or it could be Alzheimer's disease. Okay, which we find is very popular, very common in the elderly, but it is becoming a little bit more and more common in people who are not 70 or 80 years old. They're finding that some people tend to get it when they're in their early 40s or 50s. Okay? The organic can give somebody altered mental status. And it's basically, altered mental status can be caused by hyperglycemia, hypoglycemia. It can be poor perfusion in the brain. It's not getting sufficient oxygen and blood. And it could be hypothermia. The person's hot or too cold, along with many, many other medical issues. Okay? So that's organic. Organic is a temporary or permanent dysfunction of the brain caused by a physical disturbance in the physical or psychological or the psychologic function of the brain tissue. Okay? Then you've got functional. Functional is just basically a psychological disorder that impairs the body's function when the body appears structurally normal. Okay, so functional. Functional is the psychological disorder that impairs the body's function or functioning when the body appears structurally normal. The person is having difficulty moving certain extremities. Okay, but you don't physically see anything wrong with that extremity. I don't have a fracture in a bone or anything like that. Okay, so it's going to be organic or functional. Those are the two categories that doctors are going to basically categorize in a general terms when they have a patient experiencing a psychological or a behavioral crisis. Okay, so let's go ahead and get this slideshow going here. I apologize for this. So EMTs are often care for patients experiencing a behavioral crisis or psychiatric emergency. The crisis or the psychiatric emergency could be caused by many different things. It could be by an acute medical situation. Acute means it came on suddenly. It could be because the person has a history of mental illness. It could be because they have taken some mind-altering substances, drugs, illegal drugs. They could have overdosed on prescribed drugs. They could be drinking too much alcohol. They could have stress in their lives. Okay, taking into account everything that's going on in the world right now with the COVID-19, if you consider it, say you have a mom and a dad and they've got two kids, and mom was a stay-at-home mom, or say mom had a part-time job, or just say mom had a full-time job, okay, and dad had a full-time job. Both good income earning individuals, and because of the COVID-19, one parent lost their job and the other parent had their hours cut in half. So now they've lost like 75% of their monthly income, and they just bought a house 2 years ago. So the stress level has got to be through the roof in that family. They're worrying about how they're going to pay their mortgage, how they're going to pay the utilities, their credit card bills, how they're going to provide for their children with food and medical coverage. You lose your job, you lose your medical coverage. They're worried about how they're going to pay their mortgage. They don't want to lose the house. At some point, most people experience an emotional crisis. At most people, I would say everybody experiences emotional crisis in their life sometime. It's just how we deal with it. Everybody deals with them differently. Prime example, emotional crisis is you've been dating a girl for the past, or you've been dating a boy and a girl for the past 2 years. All of a sudden you guys break up. You have a death of a loved one. You loss of a job. Okay? It doesn't mean that everybody that goes through an emotional crisis develops mental illness. Okay? We cannot jump to conclusions concerning ourselves or the patient. We can't judge the patient. Just because the person's experiencing an emotional crisis or a behavioral crisis does not mean that they're a danger to themselves or anybody. It just means they're having a really hard time dealing with something in their lives. We don't know what it is. And don't judge yourself. A lot of times, if you became an EMT because you want to help people, it doesn't mean that somebody who's experiencing a behavioral crisis that you need to have a PhD to help with that person deal with what's going on and take them to the hospital. Okay, you care. You're in this business because you want to become an EMT. That's a good enough reason, and that gives you good basic qualifications in addition to becoming an EMT on how to do the basic levels of care for somebody experiencing some type of psychiatric crisis. The most common misconception is that if you are feeling bad or depressed, you must be sick. No. There are many justifiable reasons for feeling depressed. Like I said earlier, divorce, loss of a job, death of a relative or a good friend, okay, the breaking up of a boyfriend, girlfriend. Another myth is that all individuals with mental disorders are dangerous, violent, or unmanageable. That's a great test question. Okay? Another myth is that all individuals with mental disorders are dangerous, violent, unmanageable. Absolutely not. A very, very small percentage of these people who have some type of mental health disorder are dangerous to themselves, or they can become violent. A very small fraction. Okay? But as EMTs, we are going to be exposed to a large number of individuals in the community or in society who are experiencing mental health disorders or behavioral crises. Okay? Many people believe that all individuals with mental health disorders are dangerous and violent or unmanageable. Continue. Communication is key. Patients may de-escalate when a level of trust is established. You may also be able to predict violence. So, what they mean by this is communication is key. A lot of times, people who are going through a behavioral crisis or psychiatric episode, something's making them snap. Something's making them have a bad day. Sometimes they feel that nobody wants to listen to them, and that's why they're experiencing the situation that they are. And because of the way that they're acting, that's why somebody called 911, because Joey or Johnny or Julie are acting really weird today and they're scaring me. Okay? A lot of times, somebody going through one of these situations, all they want to do is someone to listen to them. Because they feel that nobody wants to listen to them. That's why they start getting upset, and that's why they start acting out. A lot of the times, if you're willing to just sit down or sit a distance from them, being aware of their posture and your posture, being aware of where your exits are if you need to get out of the room or the location really quick because the person starts to become violent. A lot of times, just talking to them and listening to what they have to say will de-escalate the situation. If you walk into a situation and the stress levels through the roof, you may be able to predict their violence. If you think you're talking to the person, and they very, very slowly try to get close to you, very slowly. You notice that they start clenching their fists. You notice that their body starts to tighten, like they're getting ready for a fight, or they're getting ready to pounce on somebody, like a predator. If they start seeming agitated, okay, you start to get a feeling, just sixth sense. Listen to it. Okay? Behavior is what you can see of a person's response to the environment, his or her actions. Okay, that's what I said earlier. Most of the time, people respond to the environment in reasonable ways. Over time, people can learn to adapt to stress, and sometimes the stress is so great in their lives that the normal ways of coping don't work, and a crisis occurs. Behavioral crisis or psychiatric emergency may involve patients who exhibit agitated, violent, or uncooperative behavior who are a danger to themselves or others. EMTs are called when behavior has become unacceptable to patients, family, or community. People, they've had it, they don't know what else to do, they've tried everything. They've gone to counseling, they've listened to the doctors, they've tried everything, and they just can't get Johnny today, Saturday, July 3rd, they just can't get him to calm down. Something set him off today, something's not right. Okay? If an abnormal or disturbing pattern of behavior lasts for more than a month, it is a matter of concern. This is an odd slide, or that's an odd statement. If an abnormal or disturbing pattern of behavior lasts more than a month, which is 30 days, it is a matter of concern. I would say that if an abnormal disturbing pattern of behavior lasts more than a week, it's a matter of concern. I wouldn't wait for a month to decide whether their behavior is out of the ordinary. Okay? When a psychiatric emergency arises, the patient may show agitation or violence, and they may become a threat to themselves or others. Okay? Because we don't experience violence in our lives every day, when somebody is very agitated and they're very angry and they're pacing back and forth, and you feel scared, you feel intimidated by them. It's not something we experience on a daily basis. So we're not used to it. So we become scared. Okay? We think they're going to do something to themselves or somebody else. That's when they decide to call 911. Okay? Mental disorders are common throughout the United States, affecting tens of millions of people every single year. A psychiatric disorder is an illness with the psychological or behavioral symptoms that may result in impaired functioning. Okay, a psychiatric disorder is an illness with the psychological or behavioral symptoms that end up affecting the way the person acts on a day-to-day basis, how they function on a day-to-day basis. Anxiety disorders are generalized anxiety disorders. There's such things as panic disorders, social and other phobias, PTSD, and obsessive compulsive disorder, like I talked about. Okay? The U.S. mental health system provides many levels of assistance. Most psychological disorders can be handled through outpatient visits, and some people require hospitalization in specialized psychiatric units. So a lot of people who are going through a really hard time, say a guy just lost his mom and his brother, and even though he's married with a wife and two kids, he feels very alone because his family's gone. He had a mom and he had one brother. And say if something happened and he lost them both in a car accident. Overnight, he's by himself. He doesn't feel like, there's nobody in his family left. And say he's like 45 years old. He has no mom to celebrate Christmas with anymore, no brother to celebrate Thanksgiving with anymore, no birthdays or anything to celebrate with them because they're not around anymore. That can make a person feel very depressed. That can make them feel very alone. Even though they have a wife and two loving kids, and they got a great family life, doesn't mean that person is not going to feel depression, anxiety. They're going to feel like they're alone. Okay, and that's when it's a good time for the family to, come together and help them through the crisis, the emotional crisis that they're going through. The emotional crisis, if it gets worse, it can turn into a behavioral crisis if it starts affecting how they behave. Okay. People who are going through a very hard time, and they need medical assistance. Sometimes the doctor will prescribe, they'll see a psychologist, and sometimes just meeting with the psychologist and talking through their issues and listening to what the doctor has to say, maybe prescribing them medication to bring to help them deal with it. Pharmacologically wise, the doctor might prescribe them to go to a support group once a week and listen to what other people are going through, and they can talk about it, sort of like Alcoholics Anonymous. You get together with a lot of people who are going through the exact same situation that you are, and you talk about it. Sometimes realizing that you're not alone and you're not the only person going through the situation, sometimes that helps you deal with it. It makes it easier because you can talk to people who are going through the same thing or a similar thing, and it makes you feel better because somebody understands what you're going through. Okay? Sometimes people, when they're going through the situation, groups, support groups are not sufficient, and they need to be hospitalized. So in the state of Rhode Island, you have Butler Hospital for adults and you have Bradley Hospital for children. And they may have to go in for a couple of days or a couple of weeks until they're stabilized. Okay? Psychiatric disorders may have underlying causes. There's so many underlying orders or underlying reasons why someone can be going through a psychiatric disorder. It could be a social or situational stress, such as divorce or death of a loved one, or loss of a boyfriend or girlfriend. It could be a loss of a job. It could be a disease where they have schizophrenia. It could be a physical illness such as diabetic emergencies. They could be hypoglycemic or hyperglycemic. If you've ever experienced somebody who has very, very low blood sugar, when they get very, very low, they tend to get very angry. I remember one where there was a gentleman, he was about 6'2", 260 pounds, and it took 4 police officers to get him under control physically because he was just going berserk. Anybody who came in to help him, the patient considered them a threat. All we had to do is get some glucose into him, and about 3 minutes later, he went back to being himself and didn't even realize what he had done. He knew he'd done something, but he didn't remember everything that he had gone through. It could be chemical problems such as alcohol or drug abuse. Alcohol, ETOH abuse. They're becoming alcoholic and they're drinking so much it's affecting their brain. Drug abuse. It could be that they're taking illegal drugs. It could be that the illegal drugs that they're taking are laced with something that is very poisonous and their body could be reacting to that. It could be they're having an adverse reaction to a new prescription medication one of their doctors gave them. It could be that they overdosed. They mistakenly took too much, deliberately or mistakenly took too much of a medication, and it's causing them to act differently. Okay? It could be biological disturbances such as an electrolyte imbalance. Everybody remembers when we talked about homeostasis. That's when all the body systems and organs are functioning in perfect harmony. Everything's working just right. Good perfusion, pulmonary, everything's working well. Cardio-wise, everything's working well. Well, it could be because you have an electrolyte imbalance and that's screwing up your entire body. The whole chemical set inside your body is messed up. Pathophysiology, as an EMT, You are not responsible for diagnosing the underlying causes of a behavioral crisis or psychiatric emergency. Doctors do that. Okay? We talked about the two differences between an organic and functional categories. Okay? Again, the organic disorder, organic brain syndrome, is a temporary or permanent dysfunction of the brain caused by a disturbance in the physical or psychologic functioning of brain tissue. Either they have a physical damage to the brain, or there's something psychologically wrong with the brain tissue. Or physiological wrong with the brain tissue. Okay? Causes may include sudden illness, traumatic brain injury, person may have had a seizure, drug or alcohol abuse, overdose, or withdrawal, and a disease of the brain, which would be meningitis. Functional disorders, which is the other one. You have the organic and you have the functional. The functional ones are a psychological disorder that impairs bodily function when the body seems to be structurally normal. It would be, perfect example would be someone with schizophrenia, anxiety conditions, and depression. Safe approach to a behavioral crisis. Okay, as a regular EMT, as a basic, you are going to use all of your EMT skills when you're in a behavioral crisis. Okay? Now, what you want to do is you want to make sure, well, listen, before I get ahead of myself, what's the next one? Okay, scene safety. So we're going to talk about the 11 steps in patient assessment. Okay, so we all know that the first step of a patient assessment is a scene size up, right? So scene size up consists of what? Scene size up consists of 5 things. Number 1, scene safety and BSI. Is the scene safe? Okay, you're not quite sure. Make sure police are there to secure the scene. BSI, you have your BSI on, your PP, you have your gloves on. Okay. You need to determine that scene safety BSI. You need to determine the MOI or NOI. If it's a psychological emergency, so it's an NOI, nature of illness, right? You need to determine your number of patients, 1 or 2, or is there more? You need to consider additional resources if you need it. Additional resources could be ALS, it could be a fire truck on scene, just for extra manpower. Okay? And you need to consider C-spine stabilization. Usually with the NOI, you don't need to consider C-spine. You don't need C-spine stabilization because there's no trauma. Okay? At that point, you've done your scene size up. The next one you're going to start with next one you're going to start is your primary survey. Your primary survey begins with your general impression of the patient. What's your gut feeling tell you? What do you see? What do you think is going on when you first see the patient? Where they are? Are they sitting, lying, standing? Are they pacing back and forth? Are they jumping up and down? What are they physically doing? Okay? Next thing you want to do is determine their level of consciousness, LOC. LOC, LOR, level of consciousness, level of responsiveness. Those two things mean the exact same things, just 2 different ways of saying it. So, AVPU, AOC times 4. AVPU is alert to verbal or painful stimuli. Are they awake or are they unresponsive? AOC times 4. Are they alert, oriented, and conscious? Do they know person, place, time, and event? Do they know their name? Do they know where they are? Do they know day of the week, what month it is? Okay? And do they know why you're there? Do they know what's going on? Do they know what was going on before you showed up? Okay? At this point, you're going to determine the chief complaint, and you're going to look for any life threats while the patient is talking to you. Is there a life threat? And as we've taught you, the life threats are 2 things, bleeding or breathing. Do you see any gross hemorrhaging? If you don't see any major bleeding, you can cut that out, and they're breathing. Are they breathing sufficiently? Are they able to talk to you in extended sentences? Are they talking to you the way I am right now? So if they're breathing, then there's no breathing life threat. So if you don't identify a life threat of bleeding or bleeding, then you move on to your ABCs. Airway. Is the airway patent? Is it secure? Breathing. Are they breathing? Are they breathing sufficiently? Okay, are they breathing too slow, too fast? If they're talking to you and they can have a normal conversation with you, then they're breathing fine. Circulation. Well, if they're breathing and they're talking to you and they're walking around, that means that they do have circulation, so that means that their heart's working. Okay? Normally at this point in time you would check the pulse, but usually with the person going through a psych patient or a psychological situation that you're dealing with, you don't want to jump right into doing that because they might think that you're attacking them. So just stand back for a few minutes. Okay? So, once you get that done, then you got your history taking, your OPQRST, your sample, your onset, provocation, Q, quality, R, radiation, S, severity, and T is time. OPQRST. Do any of those relate to what's going on? Ask the question and make sure you write down what the answer is. You want to do sample, signs and symptoms. Okay? Sign, you see what they're doing. Symptom, what do they tell you what's going on? A for allergies. Do they have any allergies? Do they have allergies to medications, certain medications, to food, environmental? Could it be that one of their allergies is the reason why they're acting the way that they are? Okay? M, medications. What medications do they take and what are they for? P, past pertinent medical history. Anything in their medical history in their past that could be affecting or causing what's going on right now. L, last oral intake. When was the last time they had something to eat? And E, events leading up to. What was going on before somebody called 911? Okay? So that's OPQRS and sample. Then you move on to your third subject, which is your secondary assessment. Secondary assessment, you're going to evaluate the affected body parts or body systems. Okay? Body parts or body systems, it's either going to be cardiovascular, pulmonary, neurological, musculoskeletal. It's either going to be the integumentary, which is the skin, a GI issue, reproductive, or psych or social issue. So out of those 8 areas, out of those 8 sections that you have to investigate, which one do you think is more involved or more attached as to what's going on here? It's going to be the psych and social one, in case you're going to concentrate on that. Okay, after that, you're going to do your vital signs. You take your blood pressure, your pulse, your respirations, take a BGL, a neural check, pupils, okay? After that, you're going to do a reassessment. Take a look at everything that you did for the patient. Reevaluate what you did. Is there anything you need to change or do differently? And then you're going to prepare your report to give to the doctor en route to the hospital. And you're going to reassess a patient every 5 or 15 minutes. Now, that is on paper. That's what you have to do in paper. Sometimes when you're dealing with a person going through a behavioral crisis, what's on paper and actually how you do it are 2 completely different things. You're still going to do everything you need to do, but how you go about doing it is going to determine how successful you're going to be doing that. Okay? So what you want to do, scene safety. Consider the scene safety and the patient's response to the environment. Take appropriate standard precautions and request any additional resources that you may need, and do it early on. Determine the NOI or MOI. Form your general impression. Begin your assessment from the doorway or from a distance. Perform a rapid physical exam. Observe the patient closely. Establish a rapport with the patient. Okay? So basically what you want to do, you arrive on scene, they're going to see you walking in, and you're in uniform, and you got a badge on, and some people might think that they're in trouble. The police are already on scene, they've secured the scene, they see the cops and they see you, you're both wearing badges. What are you? They're going to think you're a different type of cop. Identify yourself. Okay? Make sure that the scene is safe. As you approach the patient, is the scene safe? Make sure you know where all the exits are. Make sure if the person starts to freak out, you can get away from them. Don't get too close to them. Okay? Talk to them. Introduce yourself. Okay? Calmly identify yourself. Be direct with the patient. When you talk to them, look at them in the eyes and talk to them in a calm, reassuring, laid-back tone. Don't come across like you're the principal or like you're their parents or you're some person in charge of them. You need to develop a rapport. You need them to start to trust you. Okay? Talk to them in a reassuring way. Tell them you are there to help them. You're there for them. Be prepared to spend more time with a person experiencing a psychological or behavioral crisis. Don't get too close to them. Okay? Show an interest in what they want to say. Sometimes, like I said earlier, sometimes you're just going to they're going to start acting up because nobody wants to listen to them. So listen to them. Hey, my name is Brian. I'm EMT. I'm here to help you. What's going on? And they're probably going to say something like, well, what are you here for? What are you here for? It's like, well, we're here because your mom or your dad or your caretaker or one of your neighbors, they thought you're acting a little weird, and it sort of scared them a little bit. So that's why they gave us a call. So we decided to come by and check up on you, make sure everything's okay. How you doing today? Okay? If you talk to them like a friend, like a neighbor, sometimes that'll calm them down, and they'll tell you what's going on. I'm having a really, really bad day. Okay, well, what's going on? I got plenty of time. I got nowhere to go. I'm here for you. You want to talk about it? Sometimes they'll be surprised that you say that. Sometimes, I don't want to talk about it. I don't want to talk about it. It's okay if you don't want to talk about it. That's fine. You mind if I ask you a couple questions to see how your day's going, see what's going on? Because there are people here who are worried about you. Okay, they say that that you seem a little agitated. You seem a little mad, angry. They say you're screaming or yelling something earlier today. What's going on? And sometimes if you're a little persistent, but not forcefully persistent, just come across to them like a friend, like you're genuinely interested, a lot of times that'll break the barriers down and they'll start to talk to you. And the majority of the time, once they start to talk to you, you're developing that rapport with them. Don't ever lie to them. If they ask you a question, give them the honest to God truth. Okay? Don't ever lie to them because they're just like a kid. If they find out that you lie to them, they'll never trust you again. And then the entire thing is going to go through the roof. They're not going to trust you. Okay? You need to establish a good rapport, a level of trust with that patient. But you also need to observe the patient very closely and see what they're doing. Do they keep putting their hands in their pocket? What's in their pocket? Do they keep putting their hands behind them? What's behind them? Do they have a knife or a gun? Do they have a weapon stuck between their shirt and the belt in the back of their body and they're trying to get closer to you? Okay? You can basically do somewhat of a physical exam standing about 12 feet away from them, seeing how they're acting. Do they show any grimacing on their body? Do they show like they're at any level of discomfort? Are they injured? What part of the body do you think they might be injured? Okay? While you're talking with them, you're going to be assessing the airway and their breathing. If their airway is patent and they're breathing fine, they probably have good circulation. But you can take a look at their skin. Does it look, the color that it should? Then you need to make a transport decision. Do I need to transport this person right away? Are they a priority? Or can I stay and talk with this person a little while? Like I said, somebody experiencing a behavioral crisis, you're going to need to spend some extra time with them. So plan on doing that. Your company may be really, really busy, and you may only want to be on the scene for like 10 or 15 minutes. But if you need to be on the scene for 20 minutes talking to this person, trying to get this to go to the hospital so the doctors can check them out, then spend that 15, 20 minutes with them. Okay? It takes time to de-escalate somebody who's experiencing a behavioral crisis or psychiatric issue or psychiatric situation where somebody called 911 because they think the person needs help. Okay? Time is on your side, and time will greatly reduce the tension that this person is feeling. Okay? Unless the patient is unstable from a medical problem or trauma, prepare to spend time with the patient. Yep. Just like I said. History taking. Investigate the chief complaint. There are 3 major areas to consider. Is the patient's central nervous system functioning properly? Are hallucinogens or other drugs or alcohol playing a factor in the way that they're acting? And are there any significant life changes, symptoms, or illnesses involved? Are they acting this way because they're sick and they're tired of feeling this way, and they take some medication and they have a really bad reaction to the medication? Not to the point where they're convulsing, but to the point where it's just making them act weird. Okay? Life changes. Okay? Like I said, death of a loved one, death of a child, divorce, death of a spouse, loss of a job. Lots of things could be causing this patient to act out. Okay? Did they take any drugs? Or did they take medications? Too many medications? Do you see a large collection of medicine bottles, prescription bottles? Okay, do you see a bunch of alcohol bottles around? Do you see any drug paraphernalia? And again, when you do your sample, you'll be able to get the information not available to the hospital staff. You may be able to elicit information not available to the hospital staff. By talking, developing rapport with this person, you're going to get some information that probably might not be in their chart. Okay? Use reflective listening. Reflective listening is, he tells you his name, he tells you his date of birth. You repeat that back to him. Okay, John, your name is John Smith and you were born November 26, 1962? Okay, well, wow, that makes you what? How old? That's 57 years old. By repeating to them what they just said to you, it shows that you're listening because you just repeated what they just said. Not that you're being a parrot, but doing it every once in a while shows them that you're listening. Okay? Questions to ask in evaluating a mental health disorder. Does the patient appropriately answer your questions? Does the patient's behavior seem appropriate? Does it seem odd? How odd? Extremely odd or just a little bit odd? Does the patient seem to understand you? Is there a language barrier? Could there be something mentally that they're having a hard time? They speak English, you speak English, but they're having a hard time to understand you? Could something really be going wrong? Okay. Does the patient withdraw or seem detached? Do they seem hostile or do they seem friendly? Do they seem happy or depressed? Okay. The way the patient is talking to you and their expressions and the words that they're using, are they reacting and using the words and the phrases, the body language that you expect someone to use in a normal situation? Okay? Does the person or the patient seem overly aggressive? Do they seem that they can be a danger to themselves or to others, like they're going to do harm to themselves or somebody else? Okay? How's the patient's memory? Check their orientation. Again, time, place, person, and event. That's when I said you go back and determine level of consciousness, level of responsiveness. AOC times 4, person, place, time, and event. You need to determine their level of orientation. Do they know what's going on? Okay? Or are they in La La Land? Do they think they're on the moon? Or do they realize that they're in Providence, Rhode Island on 25 Main Street? Okay? Is the patient expressing some disordered thoughts? Do they have hallucinations, delusions? Do they see pink elephants walking around them? Do they see fluorescent butterflies flying around them? Are they seeing things that just aren't there? Are they hearing things that aren't there? Okay? Secondary assessment, physical examination. In an unconscious patient, begin with the physical exam. In a conscious patient, they may not respond to your questions. They may not want to talk to you. You need to spend some time with them, try to develop a rapport. Okay? You can tell a lot about a person's emotional response or emotional state with their facial expressions, their pulse rate, and their respirations. If their pulse rate's through the roof and the respirations are a lot faster than they need to be, they're probably extremely anxious. They're panicking. Why? What's going on? Have them explain it to you. Sometimes when they explain it to you, that calms them down a little bit. A blank gaze or rapidly moving eyes could mean central nervous system dysfunction. And again, your transport decision. Have law enforcement or firefighters accompany you if possible. Take the patient to a facility capable of caring for the patients with psychiatric problems and transport the patient by ground. Okay? So have law enforcement or firefighters accompany you if possible. Best thing to do if someone's experiencing a behavioral crisis or a psychological issue. Sometimes having a police officer come with you is the worst thing because they think that they're under arrest, and that might make their panic order or their anxiety even worse. Have another EMT come with you. Have a firefighter sit in the back with you. That way, it's not just you and your partner. Your partner's up driving you to the hospital, and you're in the back of the patient by themselves. What if the patient starts to get violent? Okay, it's only you and the patient. And what if the patient is twice the size of you? It's always good to have a second person in the back of the truck with you for your safety. And for the patient's safety in case something goes wrong. You need another set of hands. But it's always a good idea to have somebody back there with you. Okay? Reassessment. Never let your guard down. If the person is acting really, really calm and quiet, and they're talking to you, and now all of a sudden they're ignoring you, It could be that their psychological situation that they're going through right now, now they're becoming angry with you. You don't know why, but their attitudes, their feelings, their emotions can be like a roller coaster, go up and down. 1 minute they're talking to you, 1 minute they're not talking to you. 1 minute they trust you, the other minute they think that you're out to get them, and they need to get away from you. They need to kill you. Okay? Never let your guard down. If restraints are necessary, reassess and document every 5 minutes. Always keep an eye on their respirations, their pulse, motor and sensory function, in all restrained extremities. So if you're going to restrain somebody, you need to restrain each arm and each leg. Every 5 minutes, you check for pulse and skin color, temperature, condition. You're going to check for PMS, okay, or CSM, circulation, sensory, motor, okay, at all 4 extremities. Make sure they got a good pulse. If a pulse disappears in the left foot, that might mean that you have the restraint on a little bit too tight. You might have to loosen it up a little bit, okay. So that does that. Reassessment. Interventions: diffuse and control the situation. Intervene only as much as it takes to accomplish these tasks. If you think a pharmacologic restraint is necessary, request ALS assistance as early as possible. Communication and documentation. Give the receiving hospital advance warning of the psychiatric emergency that you're bringing in. Document thoroughly and carefully. If restraints are used, identify what type and why they were used. Okay, let's go back a second. Reassessment. Okay, first of all, when you are talking with the patient and before you put them on the stretcher or before they agree to go with you to the hospital, there's a couple more things you need to get done. Okay, like I said, you need to make sure that the scene is safe, develop good communication, assess their ABCs, okay, have a plan of action of what you want to do with the patient, okay, plan to spend more time with them, okay, by doing that, by talking with them and by listening to what they say, don't judge them, don't ever argue with them, and don't ever lie to them. You lie to them, they find out, they'll never trust you, they want nothing to do with you, they want you out of their way, okay, be direct, be honest, don't beat around the bush, okay, don't get too close to them because they could pounce on you, and there's been plenty of EMTs I've worked with that have gotten beaten up by their patients, and a lot of times, half the times, the patients are half the size of the EMT, okay, make sure you show an interest in what the patient has to say. A lot of times they just want somebody to listen to them. Don't ever fight with the patient unless you have to defend yourself, okay, but if they talk about fighting you and stuff like that, just back away a little bit and say, look, I'm not here to fight with you, I'm here to help you. Okay, let's just talk about it. Don't argue with them. You argue with them, they're going to get more upset. Be honest with them and be reassuring. I'm not going to lie to you, Joe. I'm here because your neighbor called. They said you were acting weird. Okay? I'm here to help you. Well, you're judging me, man. You must think I'm an idiot. You must think I'm really weird for acting like this. No, I don't think you're weird. I don't think you're stupid for acting like this. I think something's making you have a really hard day today. It seems like you're having a hard time dealing with something. I don't know what it is. Okay, it looks like you're trying to figure things out. And I don't know, do you want to talk about it? Talk to me about it. What's going on, man? Talk to me. Okay, a lot of times they really appreciate that. Okay? So, you continue with your patient assessment. If you need to restrain somebody, protocols in every state are different. So you need to be aware of what the protocols are of restraining somebody. But when you restrain somebody, there's certain things you need to do. Certain things you need to make sure you do correctly. Number one, make sure you can justify why you're doing it. You need to justify that they were a danger to themselves and other people. That's why you restrained them. Okay? When you do the restraint, you need to make sure that you have enough manpower on scene to do it. It just can't be you, your partner, trying to take down a 200-pound person. It's not going to work. Even if your partner is a bodybuilder, it's not going to be done correctly, and it's not going to be done safely. And you're taking a chance of somebody getting punched, somebody's getting hurt, and that just opens you up to lots of lawsuits. You need to make sure that when you're going to restrain somebody, you have at least 5 people there. at least 5 people. Okay, no matter what size the person is, even if it's a child, you need to have 5 people there. The reason why you need 5 people is you need 4 people for each extremity, or 1 person for each extremity. 1 person for the right arm, 1 person for the left arm, 1 person for the right leg, 1 person for the left leg. And you need 1 person to be in charge, and they're going to sort of take control of the head, making sure that they don't try to come up and bite somebody. Okay? When you do it, you need to have a plan. You need to make sure that you're all on the same page. You guys talk about it quickly, quietly. Okay? And when you do it, you all move in at once. Okay? You can't take 60 seconds to restrain somebody. If you're going to restrain somebody, the 5 people, you get in position, nonchalantly as best you possibly can, and then on the head person's count, boom, you all move at the same time. Okay? Stabilize the patient, get them onto the stretcher, and use the restraints that are authorized by the protocols for the department and the state that you work with. Okay? They're usually going to be, there's soft restraints, there's hard restraints. Always lay the person on their back. You can elevate the head just a little bit if you want to. Okay? Never put something in their mouth. You're usually going to use padded, thick, heavy-duty leather straps, 1 on each wrist and 1 on each ankle. And they're going to be padded with some lamb's wool. Okay? Once you secure each wrist to the sides of the stretcher and the ankles to the sides of the stretcher, then you'll most likely take a quick clip or a backboard strap, and you're going to put 1 on the shins and 1 just above the knees. Usually the one right above the knees is more effective than putting 1 on the shins, because it does not enable the patient to lift their legs as much, because it's above the joint. And then you want to put something across their hips. Never strap a person down across their chest. That inhibits their breathing. Okay? If need be, you can use some sheets to help tie the person down with if you need to. You can use a sheet to wrap around their legs. You can use a sheet to wrap around their pelvis. But you don't want to put anything across their abdomen or their chest, because that's going to make it. Or you can put 1 underneath the armpits, the way you attach somebody to a backboard. But you don't want to make it so tight where it inhibits their ability to breathe. Okay? That's how you do it. And make sure you document everything. Now, when you're taking a patient, or when you're treating a patient and you're transferring to the hospital, there's a lot of legal issues involved. You need to make sure that you know the difference between implied consent and express consent. Okay, now as you were taught when you went through CPR training, you have express consent and implied consent. Express consent is when a person looks at you and they say, yes, please help me. Yes, I don't want to die. Yes, please do the Heimlich maneuver on me. And then you have implied consent when that person who was choking now becomes unconscious. Now you can go ahead and you can start CPR on them, because you have implied consent. And implied consent is an individual who is in a life-threatening situation, who cannot answer for themselves, that it is assumed that they would want somebody to try to save their lives. So with the implied consent, when it comes to a person who's having a behavioral or psychiatric emergency, and you deem that they are a danger to themselves or others, you can have the police put the person under what we call protective custody. Protective custody is a way of placing them sort of under arrest to protect themselves from hurting themselves or hurting somebody else. But just make sure that when you do that, that you use the 5-person method to restrain the person. You all move at the same time. You make sure that the person, you're choosing to do this because they are a danger to themselves or others, and they're just not making rational decisions. And in not being able to make those rational decisions, you fear that they're going to hurt themselves or somebody else if you leave them. So they need to go to the hospital. If you're not quite sure, call med control, Call one of your officers, one of your supervisors. Best to do is call med control, explain to them what you've got, and see what they say. Okay, and see if they agree with you, or see if they authorize you to go ahead and do it. Okay, so that's what you're doing there. So I wanted to make sure I discussed how to restrain a patient, what type of restraints are used, and what are the legal issues involved. And make sure you document everything that happened. Make sure you document everything they said, everything they did, everything they threatened to do. If they threaten their brother, their sister, make sure you get the brothers and sisters' names, because I guarantee you that it's going to be evaluated by lawyers, and you're going to open up yourself to lawsuits if you do it incorrectly. If you do it correctly and you're protected, nothing will happen. But if you do it incorrectly and you don't document everything, you're not doing your job correctly, and you're opening yourself up to a lawsuit where you're not going to win. Okay? So that's where it comes to communication and documentation. You want to call the hospital while you're en route. You want to give them a heads up that you're coming with a person with a psych issue or a behavioral crisis. You deem them a danger to themselves and others, and that's what you're bringing in. You're going to be there in like 10 or 15 minutes. They would like to know so they can have extra manpower on scene. So when you show up and you transfer the patient to the hospital stretcher from your ambulance stretcher, that if extra manpower is needed, and it's usually hospital security, they'll usually call on maybe a couple of extra male nurses, big guys, to help control the person if they start to get out of control. Okay? So give them a heads up. They would really appreciate it. Hospital ERs do not like it if you show up with a psych patient and they're acting out of control and you restrain them and you haven't told them that you bring that person in. They don't like that at all. Okay? Okay, psychosis. What is psychosis and what is acute psychosis? Psychosis is a state of delusion in which the person is out of touch with reality. Okay? Affected people live in their own reality of ideas and feelings. So they're out of touch with reality. That's psychosis. An acute psychosis, acute means suddenly, all of a sudden, came out of the blue. Psychosis and acute psychosis. Acute psychosis is somebody is in a psychosis episode and it came on very quickly. It didn't take a couple of days. They woke up and all of a sudden something's not right. Schizophrenia is a complex disorder that is not easily defined or treated. Okay? Usually if somebody's a schizophrenic, they're on medications, and if they don't take their medications, then it becomes very unmanageable, and then that's usually when we get called. Symptoms and signs are delusions, hallucinations, a lack of interest and pleasure, and very erratic speech. Guidelines for dealing with a psychotic patient: determine if the situation is dangerous to themselves or to others. Clearly identify yourself. Be calm, direct, and straightforward with them. Maintain an emotional and physical distance, and don't argue with them, and don't lie to them. Guidelines: explain what you're going to do, why you're going to do it. I want to take your blood pressure, John. Is that okay? I'm going to take it by wrapping this around your left arm. I'm going to take your pulse, your respirations. I'm going to put this little thing on your finger. It's got a red line on it. It's going to measure the amount of oxygen that's in your blood. And would you mind if I did a blood glucose check on you? I just need to get a little drop of blood from your finger to make sure the sugar level in your body is fine. If the person, when you're doing your sample, you come to find out that the medications that they're on, that they're diabetic, and that they take insulin every single day. Well, did they take their insulin? And did they take their medication? And did they eat that day? Okay, if they took their insulin but they didn't eat, then they're very, very, very highly probable of being hypoglycemic. And if they're acting out physically in the danger to themselves or others, it's because they're hypoglycemic. So once you get sugar into them, once you give them some oral glucose, or you get some sugar in their body, soda, orange juice or something, they're going to start calming down very quickly. Okay? Involve people whom the patient trusts, such as family or friends, to gain the patient's cooperation and the patient's trust. You want to convince them that you are there to help them and that they can trust you. Delirium is a condition of impairment in cognitive function that can present with disorientation, hallucinations, and delusions. What is delirium? Okay? Delirium is something that's going on that's making the person not function function normally. Okay? When a person has positive or they have good cognitive functioning, it's the person's ability to process info on a daily basis and to function like a normal person. Okay? When a person has excited delirium, as I said, they have impaired cognitive function. Okay? How can I say it? It's something is going on that's making it not possible for the person to function normally on a day-to-day basis, whereas yesterday they were acting fine and today something's completely wrong. Okay? Agitation is behavior that's characterized by restlessness or irregular physical activity. Okay? They're going to have that agitation. Symptoms is hyperactive or irrational behavior. They're going to have vivid hallucinations. They will see those pink elephants. They will see the fluorescent butterflies flying around. They're going to be very, very tense. They're going to be hypertension. Their heart's going to be racing like a bat out of Hades. They're going to have tachycardia, diaphoresis, and they have dilated pupils. You need to be calm and very supportive and empathetic. You need to say, yes, I understand that you're going through I understand that you're having a hard time today. Let's talk about it. Approach the patient very slowly and respect the patient's personal space. Limit physical contact to the only time when you're doing the vitals on them, and never leave the patient unattended. Never, because you never know. Leave them unattended, you turn your back to them, they could all of a sudden reach for a knife that they had hidden underneath the pillow or for a gun that they had hidden behind a book. And you turn back around and they've got a point at you. Or they're throwing the knife at you. Okay? Be very careful when interviewing to assess the patient. Observe the patient's ability to communicate, appearance, dress, and personal hygiene. Same thing that we talked about at the very beginning of these slides. You're going to start evaluating the patient from the very second that you see them. What do you see, hear, and smell? If the patient has overdosed, take all the medication bottles or the illegal substances to the hospital with you so they can look at them and evaluate them and try to figure out how much they took. If the patient's agitation continues, request ALS assistance so chemical restraint can be considered. Uncontrolled or poorly controlled patient agitation can lead to the patient's sudden death. Okay, we already talked about restraining the patient. Every pre-hospital care transport provider should create and follow a pre-hospital patient restraint protocol. Rhode Island has their own protocols. Protocols vary widely from state to state. Okay, the restraint chosen should be at least restrictive option that ensures the safety and of the patient and the providers. Okay, personnel must be properly trained. If you restrain a person without authority in a non-emergency situation, you expose yourself to a possible lawsuit. Legal actions can involve charges of assault and battery, false imprisonment, and violation of civil rights. So, you know the difference between assault and battery, right? Assault is a verbal threat of hurting somebody, and battery is when you actually put your hands on somebody. If the person is having a behavioral crisis or psychiatric emergency, and you show up on scene and you tell them who you are, why you're there, what's going on, and stuff like that, and you're talking with them for 15, 20 minutes, and you say, I really think you need to go to the hospital, let me take you to the hospital and have the doctors check you out. The person says, no, I don't want to go. Well, I really think you need to go, sir. I said I don't want to go. Well, sir, I think you need to go, sir. No, I told you twice already, I do not want to go to the hospital. There's no need. Just leave me the hell alone. And then you make the bad decision of restraining the patient, using force, transporting to the hospital against their wishes, and they sue you. And they will win. Because you did not have consent. They told you, no, I don't want to go. Well, your reason was they were experiencing a behavioral psychiatric emergency. They weren't themselves. They couldn't make the decisions. They weren't thinking right. Okay, the judge is going to say, okay, well, let me ask you a question. Did you ask them when you did your primary survey? And you were determining their level of consciousness? Did you ask them? The AOC, alert-oriented conscious times 4. That's 4 things. Are they aware of person, place, time, and event? Did they know their person? Did they know their first and last name? Yes, sir. The patient said his name was John Smith. The judge says, okay. Place. Did they know where they were? Yeah, they said yes. The patient said they knew that they knew that they were home, And Judge even said, what's your address? And they said their address was 150 Main Street, and that was correct. And the judge says, okay. Time, person, place, time. Did the patient know what time it was? Yes, sir. They knew that it was Monday afternoon, July 4th weekend. The judge is going to say, okay. An event. Did they know what the event was? And you as EMT say, yes, Judge. They said they were having a really, really bad day. They decided to go in the backyard. They were really angry, frustrated. They started screaming, they're throwing things around. And that's why they were doing it. They were just really, really agitated at their wife because they had a big fight. And she asked them for a divorce. The judge is like, okay, so the person answered, the person, place, time, and event. They answered all your questions correctly. They knew where they were. And you decided to take them against their will to the hospital, even when you determined that the level of consciousness was correct. Yes, sir. Okay. And the judge is going to say, I will allow this lawsuit against you to proceed because you assaulted. The charges of assault and battery will let the case go through because you did commit battery on this person. You took them against their will, and you had no right to take them to the hospital because you did not have consent. So you will lose that lawsuit. Okay. You may only use restraints to protect yourself and others from bodily harm, including the patient, to prevent the patient from injuring himself or herself. Involve law enforcement if the patient is in severe behavioral crisis or psychiatric emergency, and before considering physical restraint, use verbal de-escalation techniques. Talk to them. Ask them what's going on. Tell them you're generally interested and find out what's going on. The process of restraining the patient, carry out the decision quickly. There should be 5 people to help, 1 responsible for each extremity and 1 person responsible for the head. There should be a team leader and plan of action, and you need to use the most minimum force necessary. There's no need to body slam the person up against the floor. Grab them, gently put them down, and then restrain them. The level of force will vary depending on these factors: the degree of force that is necessary to keep the patient from injuring themselves or others, the patient's sex, size, strength, and mental status, and the type of abnormal behavior the patient is exhibiting. If you have a female and you have all males restraining this patient, you might want to try to wait to get another EMT, female EMT, or 2 female EMTs, or a female EMT and a female police officer there, okay, to verify that nobody's doing anything to or with the patient that they shouldn't be doing. Talk to the patient throughout the process. Treat the patient with dignity and respect. Just because you had to restrain them does not mean that they're a bad person. It just means they're having a hard time. Okay? If possible, a provider of the same gender should attend to the patient and wear appropriate barrier protection. Make sure you have your gloves on. If the patient tries to spit at you, put a mask on them. Okay? Put a surgical mask on them. Avoid direct eye contact and respect personal space. Never leave a restrained person unattended. Use the 4-point restraints and monitor the patient very closely. Make sure you check their CSMs on each extremity every 5 minutes. Make sure you check their vitals at least every 15 minutes, if not sooner, while you're in transport. Potentially violent patient. Violent patients make up only a very small percentage of patients undergoing a behavioral or psychiatric crisis, and be alert for signs of potential violence. History. Has a patient previously exhibited hostile, overly aggressive, or violent behavior before? And the patient's posture. How is the patient sitting, or are they standing? Is the patient tense, rigid, or sitting on the edge of his or her seat like they're ready to pounce out and jump on you? The scene. Is the patient holding or near a potentially lethal object? And vocal activity. What kind of speech is the patient using? Are they loud, obscene language, erratic speech, bizarre speech? Okay, or patterns usually indicate emotional distress. Are they crying a lot? Physical activity, most telling factor of all. A patient requiring careful watch is one who has tense muscles, clenched fists, or glaring eyes. They're pacing back and forth. They can't sit or stay still, and is fiercely protecting personal space. Okay? Other factors include poor impulse control, a history of truancy, fighting, or uncontrollable temper, a history of substance abuse, a history of depression, and any history of functional disorders. A patient who has experienced suicide or a patient who has attempted suicide, depression is the most single significant factor that contributes to suicide. It is a common misconception that people who threaten suicide ever commit it. Someone with suicide, someone who attempts suicide, a lot of the time from what you'll experience in the field, the person will do something to themselves physically. Not to the point where they're going to be successful in killing themselves, but in the event or in the process of, it's going to draw attention to themselves. And it's their way of crying for help. They're asking for help. They slice their wrists. If you slice your wrist going the opposite direction, you're really not going to kill yourself because of the fact, the way that the blood vessels constrict where the cut site. Okay? If someone's going to overdose, they might overdose on something that they didn't take enough of it. Okay? Usually a person who talks about suicide or tries suicide for the first time, it's their way. They're screaming for help. They're asking for help. Okay? What you need to do is let them know you're there for them and you're going to take them to a place where they can be helped. And you're not going to judge them. Be alert for these warning signs. Air of tearfulness, sadness, deep despair, or hopelessness. Avoiding making eye contact with you. They speak very, very slowly, and they project a sense of vacancy, like they're talking about themselves in the third person. They can't talk about the future, because as far as they're concerned, they don't have a future. They suggest suicide. You want to find out if they have a plan. I'm going to kill myself. Okay, well, you want to tell the doctor that the patient said, I'm going to kill myself. But then you want to ask the patient, well, okay, if you want to kill yourself, I'm sorry you feel that way. I hope you don't, because you seem like a really nice person to me. But if you were going to kill yourself, did you have a plan? How are we going to do it? A lot of times people just say, I don't know, I was thinking about it. But they come up, well, I had a plan. I was going to wait till next Thursday night when my girlfriend comes home. I've got a gun, and I was going to go in the bathroom and shoot my brains out after dinner. That means that they had a plan. That's just talking about suicide compared to talking about suicide, and then you have a plan of how you're going to do it. That means that the person's thought it out. Is it a general plan, or are they very specific about date, time, and how they're going to do it and how fast it's going to take for them to die? Okay, that shows the level of seriousness on their part. You want to make sure that you document that and you let the doctor know. Okay, and they're having plans related to death. You guys can take a look at your risk factors for suicide, chapters 22-3. I'm sorry, table 22-3. But these are general things that we've already talked about. Consider these additional risks. Are there any unsafe objects nearby? Okay. Is the environment unsafe that you're in or that they're in? Is there evidence of self-destructive behavior? Do you see if they slice their wrist? Okay. Do you see the evidence of that? Is there an immediate threat to the patient or others? Did they slice their wrist and they're bleeding a little bit, or the bleeding stopped by the time you show up and they're still holding the knife that they cut themselves with? Okay. Or do they have a gun in their hands or threatening to blow their heads off? Additional risk: is there any underlying medical problems? Are there culture or religious beliefs promoting the suicide? Has there been a trauma? Okay, a suicidal patient may be homicidal as well. Someone who's really deadly serious about it, they don't care whether they take you with them. So they may have a bomb. Okay, they may shoot you and shoot them. They just don't care so much, and they're so angry that they don't care if they take anybody out with them. Okay, PTSD. PTSD occurs after exposure to or injury from a traumatic event. An estimated 7 to 8% of the general population will experience PTSD at some point in their lives. I think that's probably increased a little bit since these slides have been made, because I don't think we had the Gulf War, maybe we have everything going on in the Middle East at the time. Military personnel with combat experience have a very high incidence of this. Symptoms of PTSD include feelings of helplessness, anxiety, anger, and fear. Anger, because why did my buddy die? Why didn't I die? Anxiety, they're having a hard time transitioning from the war zone back to normal civilian life. Helplessness, they just don't know what to do. And fear, they're worried about their future. People with PTSD may avoid reminders of the trauma. suffer constant nervous system arousal, can relive the traumatic event through thoughts, nightmares, and flashbacks. They may avoid, oh, no, sorry about that. May avoid reminders of the trauma. If somebody was in a war zone, they may not want to go to the 4th of July fireworks because the loud explosions remind them of the battlefield. Suffer constant nervous system arousal. Everything around them, honking horns, dogs barking, loudspeakers loudspeakers will be setting them off. Veterans have an increased risk of suicide. Veterans may develop a variety of physical conditions related to combat injuries, and combat veterans have a higher incidence of post-traumatic brain injury. Caring for the combat veteran requires a unique level of understanding. Be careful how you phrase your questions. Use a calm, firm voice, but be in charge. Respect the veteran's personal space, limit the number of people involved, and ask about suicidal intentions. Caring for the combat veteran continued. Ensure that there is nothing the patient can access and use as a weapon. Physical restraints may simply escalate the problem. Yeah, I would not want to be one of the people trying to physically restrain a combat veteran because they'll probably kick my butt and everybody else's butt there. Okay? More medicological considerations, more complicated with the patient undergoing behavioral crisis or psychiatric emergency. You must decide whether the patient needs immediate emergency medical care. The patient may resist your attempt to provide care. Never leave the patient by themselves, and request law enforcement and personnel to assist with the patient if necessary. Make sure that you get consent. It's express consent or implied consent. Okay? If they give you express consent, they say, yes, please help me. Yes, I want to go to the hospital. Okay, great. Implied consent. If the person took something and they finally pass out because they overdosed on something, now you have implied consent. Also, implied consent also is the person cannot make rational decisions. They're so off the wall, they have no idea what's going on. They're so out of touch with reality that you think that they are going to hurt themselves, they're going to do something dangerous to hurt themselves or somebody else. So then you request the police to put them under protective custody. Now you're taking them against their will. But you need to make sure you document everything, what you did, why you did it, to cover your butt, and also to show them that that's why you had to restrain the patient, take them to the hospital against their will. Okay? So implied consent is assumed when a patient who is not mentally competent or implied consent is assumed with the patient who is not mentally competent to grant consent. So that's the type of consent we're talking about. Consent matters are not always clear-cut in psychiatric emergencies, and if you're not sure, request the assistance of law enforcement personnel or guidance from med control, like I said earlier. Call med control if you're not quite sure what you need to do. Limited legal authority. We as EMTs, we have limited legal authority to require a patient to undergo emergency medical care when no life-threatening emergency exists. Okay? Competent adults have the right to refuse care. If they don't want to go and they can answer all your questions correctly, there's no need to go. Even if you go to a nursing home, the nurse wants you to go. The owner of the nursing home is demanding that you take them. If the patient can answer all your questions correctly and their person, place, time, and event, and they're talking to you and they see very rational, then you do not have to take that person to the hospital. Okay? In psychiatric cases, a court of law would probably consider your actions in providing life-saving care to be appropriate. A patient who is in any way impaired may not be considered competent. You need to maintain a high index of suspicion about the patient's condition and err on the side of treatment and transport rather than walking away. Okay? So, now we got the chapter review. Question number 1. A behavioral crisis is most accurately defined as what? Would it be a severe acute psychiatric condition in which the patient becomes violent and presents a safety threat to themselves or others? Would it be B, any reaction to events that interferes with activities of daily living? C, a normal response of a patient to a situation that causes an overwhelming amount of stress, such as the loss of a job or marital problems. Or D, a reaction to a stressful event that the patient feels is appropriate, but is considered inappropriate by the patient's family or community. The answer on this one would be B, I believe. Yep. A behavioral crisis is any reaction to the events that interferes with the patient's activities of daily living or has become acceptable to the patient, his or her family, or the community. Not all patients with an emotional crisis are psychotic, nor are all violent patients experiencing a psychiatric condition. These are common misconceptions. Various medical conditions can cause a behavioral crisis. Number 2, depression and schizophrenia are examples of what? Functional disorders, altered mental status, behavioral emergencies, or an organic brain injury. I think it's A, functional disorders. Yes. Number 3, when assessing a patient with a behavioral crisis, your primary concern must be what? Allowing the patient to express himself or herself to you in their own words. B, setting your personal feelings aside and providing needed care. C, gathering the patient's belongings and taking them to the hospital. Or D, whether the patient will cause harm to you or somebody else. And this would be, I think it's a D. Yep. There are many things that you should consider when assessing a patient with a behavioral crisis, including all the items listed in this question. Your primary concern, however, must be the safety of yourself and your partner. And remember, when we first talk about it, scene safety, BSI, boom, right there, scene safety, yourself and your partner. General guidelines to follow when caring for a patient with a behavioral crisis include all the following except what? Being honest and reassuring, yes. Rapidly transporting the patient, well, yeah, you're going to do that. Having a definite plan of action, yep, you need that. And avoiding arguing with the patient, yep. So I think the answer would be B. Yep, when caring for a patient with a behavioral crisis, the EMT must be prepared to spend extra time with the patient. It may take longer to assess and listen to the patient prior to transport. Reflective listening, an assessment technique useful when caring for patients with an emotional crisis, involves what? Asking the patient to repeat his or her statements. B, simply listening to the patient without speaking. C, asking the patient to repeat everything that you say. Or D, repeating in question form what the patient tells you. D, reflective listening, a technique in which you repeat in question form what the patient tells you. Allows the patient to further expand on his or her thoughts. It also helps the EMT gain insight into the patient's situation, and it also signifies to the patient that you're listening to them. Which of the following patients is the highest risk for suicide? Is it a 24-year-old woman who is successfully being treated for depression? Is it a 29-year-old man who was recently promoted with a large pay increase? Wow. C, a 33-year-old man who regularly consumes alcohol and purchased a gun? Or would it be D, a 45-year-old woman who recently found out her cancer is in full remission? I would say it's probably going to be C. Yeah. Drinks a lot and bought a gun. Not a good idea. Not a good combination either. 7. When caring for a patient with an emotional crisis who is calm and not in need of immediate emergency care, your best course of action would be to what? A, advise the patient that he or she cannot refuse treatment. B, lead the patient with a trusted friend or family member. C, attempt to obtain consent from the patient to transport. And D, apply soft restraints in case the patient becomes violent. I think it's C. Yeah. Just because the patient is experiencing an emotional crisis does not mean that he or she is mentally incompetent and cannot refuse EMS treatment and or transport. You should attempt to obtain consent for any conscious patient unless he or she clearly does not have decision-making capacity. Number 8. When physically restraining a violent patient, the EMT should what? Continually talk to the patient as he or she is being restrained. Check circulation in all extremities only if the patient is prone. Remove the restraints if the patient appears to be calming down, and use additional force if the restrained patient begins to yell at you. I think it's A. They want you to constantly talk to the patient, walk them through it. When physically restraining a violent patient, the EMT or his or her partner should continually talk to the patient throughout the process, treat the patient with dignity and respect, regardless of the situation. Once restraints are placed, they should not be removed, even if the patient appears to be calmed down. Let the doctors remove it at the hospital. Circulation in all extremities should be monitored regardless of the position in which the patient is restrained. Number 9. Upon arrival at the residence of a young male with an apparent emotional crisis, a police officer tells you that the man is acting bizarrely. If you find him sitting on his couch, he is conscious but confused. He takes medications but cannot remember why. His skin is pale and diaphoretic, and he has noticeable tremors to his hands. You should first rule out what? Hypoglycemia, suicidal thoughts, severe depression, or schizophrenia. Hypoglycemia. Okay? Numerous physical problems can cause bizarre behavior such as hypoglycemia, hypoxemia, and brain tumors, among others. The EMT should rule out an underlying medical issue caused first. The patient's pallor, diaphoresis, and motor tremors suggest hypoglycemia. The EMT should assess the patient's BGL level, if trained to do so, which you are, and consider administering oral glucose. Psychiatric illnesses such as clinical depression and schizophrenia cannot be ruled in or out in the field. Those are doctors who do that. We don't do it. Finally, which of the following signs is least indicative of a patient's potential for violence? A, the patient appears tense and edgy. B, the patient is 6 feet 5 inches tall and weighs 230 pounds. C, the patient is loud and shouting obscenities. Or D, the patient is facing you with clenched fist. Which of the following signs is least indicative of a patient's potential for violence? I would say it's B, the patient is 6'5" tall and weighs 230. Doesn't make a difference to their size. What are they doing that's giving you a possible feeling of threat, of violence? And other than that, that is it. Okay? Continue reviewing the chapters. Make sure you are understanding the glossary terms at the back of the chapter. Make sure you stay up to date with your JBL work. Everybody stay safe. Please practice your social distancing, 6 feet apart. And I'll talk to you again when we do the next chapter. Thank you very much and have a good day, everybody.